Good afternoon, and thank you for joining the RLS Foundation's webinar titled The Ins and Outs of RLS from an RLS Expert. My name is Zibby Crawford, and I'm the Membership Services and Marketing Coordinator of the Foundation. The surge in the use of web-based programs during the COVID-19 health crisis has created a strain on the system. If you're experiencing technical difficulty, switch to audio. There should be a telephone number listed on your invitation, as it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with our technical difficulties that may arise during today's webinar presentation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Today's presenter, Dr. Denise Sharon, will answer as many questions as time allows following her presentation. After the webinar, you will receive an email with a link to the webinar recording. Dr. Sharon works as an independent consultant out of the Sleep Disorders Adult and Children's Center of the Pomona Valley Medical Center in Claremont, California. Throughout her education, training, and work, Dr. Sharon has amassed research experience including, but not limited to, work as a research associate, quantitative electroencephalographer in the Laboratory of Psychoelectrophysiology, Department of Psychiatry and Health Behavior through MCG. Her research has been published in numerous journals, as well as industry-supported pieces on restless leg syndrome for Pfizer, Xenoport, Luitpold, and more. Dr. Sharon has been involved in multiple committees for the American Association of Sleep Medicine, such as the Center Accreditation, Fellowship Accreditation, Nosology Committees, and Movement Disorders Section, where she served as Vice President. She is a member of the International Restless Leg Syndrome Study Group and the American Academy of Sleep Medicine Task Force on the update of the treatment of RLS and PLMD, just another way in which she is helping those with RLS. Sharon serves on the Foundation's Pediatrics and Quality Care Center certification committees on our Scientific and Medical Advisory Board. Thank you, Dr. Sharon, for sharing your time and expertise with us today. Please begin.
Thank you, Zibby, for such a wonderful introduction, such a warm one. And hello to everybody. Thank you for this opportunity to discuss the in and out of RLS, or maybe shall we say, when RLS is in, sleep is out. Next slide, please. I have no conflict of interest in relating to these presentations. Next slide, please. This webinar was prompted by you, RLS Foundation members, that have sent in your questions. These questions are really good, very thought-provoking. Sometimes we do scratch our heads trying to answer them. So please keep them coming. You can find excellent information, updated information on the RLS Foundation website. The RLS Foundation has been very important in the education and advocacy programs for RLS. Recently on the website, it has been published an updated algorithm for the treatment of RLS that you can find there as well. And I think they have been doing an amazing job for the past 40 years. I think it's just 40 years ago that it was established, or pretty much around that. Some of the researchers encouraged by the RLS Foundations started the International RLS Study Group that has been developing diagnostic criteria, diagnostic severity scales, and quality of life scales to study RLS. So there is some information on those websites. And also there is the American Academy of Sleep Medicine website that helps developing diagnostic criteria and treatment guidelines and outcome measures for RLS. So those are some wonderful resources to learn more and understand more about this really extremely bothering disease. It's very tough on the patients. RLS is viewed, restless leg syndrome is viewed as a chronic sensory motor disorder that can affect and frequently affect sleep. I believe that all of you are familiar with the symptoms of RLS. We are talking about an irresistible or almost irresistible urge to move the legs that is triggered by rest, relieved with movement, and prominent at night. And symptoms can get really bad. Next slide, please. We differentiate two types of RLS, the one that starts earlier in life, before the age of 45, mostly genetic. It's a little bit, tends to be a little bit easier to control the symptoms. And the late onset one, the one that starts after the age of 45, with a faster progression, and symptoms tend to be more severe sometimes. And our restless leg syndrome has a significant impact on sleep and the sleep-wake cycle. And that's how it tends also to affect the quality of life. Obviously, with sleep deprivations, with sleep problems, there is less quality of life, tends to affect relationships. It's sometimes associated with pain and increased morbidity, increased tendency to get other problems, other diseases. And obviously it can affect performance, and it has societal implications and a cost associated with those. The symptoms can appear occasionally, on and off. I had patients that were mentioning, oh yeah, maybe 10, 15 years ago, I occasionally had symptoms, and probably most of you are familiar with it. They can be seasonal, or they can be periodic, like during pregnancies. There are weekly symptoms that would have occur maybe twice up to 3 times a week, or in many cases it's daily. And in many cases, symptoms tend to be severe, not really responding to treatment. And those are mostly the cases that we see also with augmentation. Next slide, please. The current understanding is the restless leg syndrome is a multifactorial disease. It has a genetic basis that we were not able always to completely figure it out, but it's extremely common in many patients. Richard Allen, Chris Orley, Jim Connor, and their associates at both Johns Hopkins and Penn State promoted the study of iron in RLS, and they developed a large body of research that supports the hypothesis that RLS symptoms result from reduced availability of iron in the brain, and that leads to a dysregulation of dopamine in the brain. In addition, we do have the impact from glutamate neurotransmitters and from adenosine neurotransmitters. The dysregulation of dopamine can also cause increased spinal cord excitability, and that has been seen, frequently seen in RLS patients. Next slide, please. We are still missing a biomarker, a good test to diagnose RLS. So the diagnosis is clinical and subjective to the patient perception and also to the clinician expertise. Next slide, please. The management of restless leg syndrome starts with the assessment of iron stores, blood work for ferritin, transferrin, iron binding capacity, and serum iron. Ideally, we could check iron in the cerebrospinal fluid, but it's not feasible to have spinal taps on everybody. So we are trying to imply from iron, from the iron stores in the blood to what might be happening in the brain. And that's not always accurate, but that's our attempt up until we have better biomarkers. So following those results, we can decide on modalities of treatment. Can be behavioral, pharmacological, interventional, or any combination of one or more modalities, and also on the frequency of the treatment. Treatment for RLS symptoms can be as needed, on an as needed basis, maybe occasional, up to once or twice a week, or on an everyday basis, and maybe even twice a day. Next slide, please. So when I'm talking mostly about management of RLS symptoms, treatment is a more definitive elimination of symptoms, and that's not what we do tend to see in most cases. Most cases, we are talking, the goal is to control symptoms of RLS and to accept maybe a little bit of disturbance, and in order not to have more side effects from different treatment. So we're talking about behavioral and lifestyle modifications, supplemental iron. Management can involve pharmacological compounds, but those have been associated with augmentation, impulse control disorders, sleepiness, drowsiness. And sometimes there is a need to add sleep promoting or alertness decreasing medications. I'll mention a little bit about over-the-counter substances and supplements and non-pharmacological interventions. Next slide, please. When we are talking about behavioral and lifestyle modification, first, it's important to engage in mental alerting activities, because we know that RLS symptoms start usually during periods of rest and relaxed mental activity. So mental alerting activities, discussing, being involved in anything, playing music or any other activities, can relieve or avoid triggering those symptoms. The caveat with mental alerting activities is that at bedtime, we are also trying to relax and get ready to bed. So that's a little bit of a contradiction here. It's really important to maintain a regular sleep-wake routine, because we know that sleep deprivation can worsen those symptoms. If possible, I'm also recommending usually to delay wake time. Most patients, and you might be aware of it, report that their next best sleep is in the early hours of the morning, when almost everybody experience no symptoms, even if it's for a short period of time. So ideally, to find occupations that do not require you to be up at 5 a.m. might be a good idea. And if you can delay the wake time, can help you benefit from those hours with no symptoms. Also, it's important not to spend wake time in bed, because that, because of the rest can increase the symptoms of RLS. In terms of the diet, the important things that we know, the ones that we know about, is to limit caffeine and alcohol. And those have been reported in numerous studies and very numerous reports from patients that trigger restless leg syndrome. So ideally, it's completely eliminating. If I'm pushed, I'm asking, okay, so you can try to have a cup of coffee in the morning and see what's happening. And if absolutely alcohol is needed, maybe earlier in the day rather than later in the evening. Also, it's important to maintain a healthy weight, because obesity seems to be triggering other sleep disorders that can trigger sleep deprivation that can worsen RLS. And there are some reports that sugary and fatty foods, processed food, may also trigger restless leg syndrome, but those are not really evidence-based. In terms of exercise, it's important to maintain a level of exercise, but avoid high impact training. Leisure walks, stretches in the early evening or afternoon are recommended. And if the exercise is more actively involved, it should be done in the morning. There are several reports, well-controlled reports, that yoga, in particular the younger, is helpful for RLS symptoms. So definitely I'll encourage that one. Next slide, please. When we are talking about supplemental iron, we are talking about oral iron with ferrous sulfate, 325 milligram. The key here is the 65 milligram of elemental iron, in addition to vitamin C, 100, 200 milligram of vitamin C. Ideally, the oral iron should be taken on an empty stomach. Definitely avoid calcium-rich foods. And from some study on primates, we understood that iron absorption tends to be better in the evening. So it's better to take it in the evening. Depending on the results of iron store, the supplement or supplement the iron, and that would be the first line of RLS treatment. IV iron is recommended and can be a successful way to treat symptoms of RLS. The most commonly used is ferric carboxymaltose, 1,000 milligram in one dose or two doses of 500 milligram at about a week interval. Different centers may use different iron preparations, and it's important to check with your doctor and discuss it ahead of time. Next slide, please. Pharmacologic compounds that are used for the treatment of RLS include the opiates, the alpha-2 deltas, and dopamine agonists, and there have been other medications as well that continue to be used on a smaller scale. The most used opiates includes tramadol, codeine, oxycodone, hydrocodone, methadone, and buprenorphine. Those are effective treatment for RLS symptoms. They do reduce symptoms significantly. They do improve sleep and reduce daytime tiredness. They do improve quality of life. The most common side effects include nausea, constipation, and urinary retention. Drowsiness, unsteadiness, and confusion can be seen mostly with the elderly, 65 and older. And opiates can decrease the respiratory drive. They can have an effect on breathing and trigger more central sleep apnea events and obstructive sleep apnea events. So if somebody has both RLS, restless leg syndrome, and obstructive sleep apnea, we just need to make sure that they are using the CPAP or they are treating the obstructive sleep apnea otherwise. Interesting enough, we do see low addiction rates to opiates in RLS patients, and there is very little need to increase the dose once an optimal dose is achieved. So the RLS patients do tend to develop less tolerance than otherwise. However, the problem with the opiate is that there may be some stigma associated with it. And there are some potential problems that they can cause in terms of renewing licenses, for example, piloting, flying licenses, and so on. Sometimes it's harder to find providers willing to prescribe opiates, and the RLS foundations does an amazing job in helping patients to find providers and in advocating for the use, for the ability of patients with RLS to use opiates. Next slide, please. Alpha-2 ligands and gabapentinoids, how they can be called, are a group of medications that are working on the calcium channels. And gabapentin is usually used in starting 1 or 2 hours before symptoms start, with a starting dose of 300 and less in the elderly, 100 or so. And doses can be increased to up to 1,200, 1,800. Usually it's enough to treat RLS patients, but have been increased up to 3,600 milligram. Gabapentin has a very wide range in terms of the treatments. Pregabalin, similar to gabapentin, is given within the 2 hours before symptoms do start. It's usually starting at 75 milligram, 50 milligram in the elderly, and usually 150 milligram to 450 milligram is the regular dose. Gabapentin and acabril or Ryzend is the only medication here that's approved by the FDA for the treatment of RLS. And the dose is usually 600 milligram, less in the elderly, again, 300 milligram. and it can, in rare occasions, it goes up to 1200 milligram. The alpha-2 delta ligands are effective in treating RLS symptoms. They reduce the severity of them and the frequency of the symptoms. They do reduce pain and anxiety, and they can promote sleep. In terms of side effects, they are associated with drowsiness, dizziness, cognitive effects in the elderly, sometimes weight gain, depression, and in rare occasion, decrease of respiratory drive. The caveat with using the gabapentinoid is the renal dysfunction, kidney disease. And it's really important to discuss it with the treating physician. Next slide, please. Dopamine agonists are the mostly researched medications used for restless leg syndrome, and many of you probably have been or continue to be on dopamine agonist. They are promptly effective, immediately, to the point that at some point they were used in order to help with the diagnosis of restless leg syndrome. Within half an hour, the effect, particularly with carbidopa, levodopa, the effects are almost immediate. The problem with the dopamine agonists that we started noticing after using them for longer periods of time is with their side effects, with creating the augmentation, the worsening of symptoms in the long run. Because we need to go back to the pathophysiology and recall that restless leg syndrome is not a disorder of the dopamine, but it's a disorder that's associated with decreased availability of iron that's imported in the synthesis of dopamine. So that we have more of a dysregulation of dopamine rather than an absence. So that explains why continuous use of dopamine agonists can create more of a dysfunction of dopamine rather than regulate it. We do still use low dose of dopamine agonists because of the really significant effect on restless leg syndrome symptoms. It probably is not going to be anymore the first line of treatment recommended, but maybe in combination with other modalities, and keeping the doses as low as possible. And also trying to use the longer acting compounds as opposed to the shorter one that seem to be associated with increased augmentation, and also maintain adequate iron stores. So again, checking the iron stores. The dopamine agonists that we are currently continuing to use include the carbidopa, levodopa, around 25 to 100 milligram, and that's for occasional symptoms, not more than 3 a week, in order to avoid augmentation. Ideally, maybe once a month, once a week. If somebody has a long flight with problems with restless leg, they can use that. Ropinirole, the lowest dose, 0.25, up to maximum 2 milligram a day, ideally less than that, within 1 or 2 doses, 1 to 1.5 hours before symptoms start. So with dopamine agonists, we do try to start them just before symptoms are starting, an hour or an hour and a half just before symptoms start. But in those occasions when symptoms start early in the afternoon, there might be a need for an additional dose in the evening. Pramipexole at 0.125 to 0.5 milligram, again, a couple of hours before symptoms start. And the rotigotine patch, that's long-acting, that's 1 milligram up to 3 milligram a day, once a day. And that's a longer-acting dopamine agonist. Another important side effect that sometimes it's not discussed so much is the impulse control disorder with hoarding, gambling, different impulse control disorders that are much more common with dopamine agonists, and they need to be accounted for. Next slide, please. In terms of other options, benzodiazepines tend to improve sleep and reduce anxiety, but their effect on restless leg syndrome symptoms is not clear and probably not really, they don't really have an effect on it. Carbamazepine has been reported efficacy in small studies, and it has been used. The effect is similar to the alpha-2 delta ligands, so probably those would be preferred. On clonidine, that's a medication that tends to reduce blood pressure and can cause problems with orthostatic hypotension, more so in the elderly. We did need more data regarding its effect for restless leg syndrome. It has been used a little bit more in children, where the reducing in blood pressure is not that much of a concern. And there are some new developments for potentially new medications that may increase the adenosine, they may decrease glutamate, and also there have been more developments with non-invasive electrical stimulation. We also, hopefully, at some point, will be able to have a biomarker of intracranial iron that would help with the treatment as well. Next slide, please. Now, an important aspect of the treatment of restless leg syndrome is managing the sleep. And for that, we can use behavioral and cognitive strategies. If needed, sleep-promoting medications. If the difficulty is mostly at bedtime, when with the ability to fall asleep, for initial insomnia, then zolpidem 5 to 10 milligram and zalopram 5 to 10 milligram might be used. If the difficulty is more with awakenings during the night and difficulty resuming sleep, then maybe temazepam or ezopiclone at 1 to 3 milligram can be used. Now, apart from the sleep promoting medications, wake decreasing medications have been developing lately, and there is no data on restless leg syndrome and wake decreasing medications. Currently, suvorexant is the subject of a clinical trial on RLS, and I believe the information is on the RLS website. I had a question regarding a different weight decreasing medication, and there are no clinical trials with it yet. So it has just been FDA approved. A better sleep can improve quality of life, can improve performance, but medications to promote sleep have been associated with daytime drowsiness, risk of falls, and cognitive difficulties in the elderly. So there needs to be here a balance. So ideally, we'll go to the behavioral and cognitive strategies before starting medications for sleep. Next slide, please. There are many over-the-counter products and supplements that are touted as improving restless leg syndrome symptoms and sleep. Tylenol can relieve pain. Melatonin may improve sleep to some degree for limited periods of times. Vitamin D, there is very limited data, but supportive data. Regarding magnesium, we have not really evidence, not enough evidence about it. I had a question regarding cannabis, and we don't have evidence-based data. Regarding anecdotal evidence is that for the inhaled one, and it seems that the benefits are short-lived, but if difficulty to sleep is the main thing and it can help, sure, we probably need more data about it. But also cannabis can interfere with other treatments, and that one needs to be taken in account. There are many others that are really we have no evidence and no information, no good information about them. Non-pharmacological interventions include massages, hot or cold baths, and there are anecdotal reports about their efficacy for symptoms of RLS. Those are the oldest mentioned therapeutic modalities for RLS in both Western and Eastern cultures. So it's somewhat surprising that we really do not have good evidence-based data on that. One of the problems is that sometimes it's hard to come up with placebo-controlled studies. There are a few studies on different massages with old and their effect on RLS symptoms, and they seem to have a little bit of an effect, but those are not well-controlled studies. Regarding Botox, botulinum toxin injections, there are some conflicting reports. Again, a couple of reports that suggest some improvement. It's not clear for how long it's going to last, and again, not well-controlled studies. Regarding compression stocks and vibration devices, again, anecdotal reports, limited data, not uncontrolled studies. Regarding the electric and magnetic stimulation, we did see variable results in a couple of very well-controlled studies. And I think there may be an avenue there that needs further explorations. Surgeries, all kinds of vein type of surgeries were promoted for restless leg syndrome. If any effect from them, it was probably a misdiagnosis of restless leg syndrome. So for the time being, there are no surgical interventions that we can discuss. So in summary, currently we have a better understanding of restless leg syndrome, its genetics and pathophysiology. Using neuroimaging techniques, we can see the neuroanatomic and functional changes. We also developed a better understanding of the clinical course of the disease and and also of the symptom management, frequently using more than one modality. We had a treatment setback, and that was documentation, and but we learned from it. We learned from it the importance and the need for long-term efficacy and safety study for any treatment, any intervention that we are planning. And that's maybe what prompted so many new reviews of literature, reviews of guidelines, updating guidelines for treatment for restless leg syndrome. And I would like to thank you and would be happy to answer any additional questions, comments, and suggestions. I have already received a list of questions, and I would like to get to it in one moment to be able
Thank
to
you,
read.
Dr. Sharon. I'll ask the questions and you can give the answers. How's that?
Okay, that
So,
sounds like a good plan. Hold on one second.
so the first question is, are higher levels of anxiety associated with RLS?
Second, let me see here if I can find those, because I had a couple of, okay, let me see. No, it's not yet. Yes, the first answer is yes. I have a little bit of a more detailed answer for it. One second, let me see if I can get to, okay, now I have the questions too. One second. So the main answer regarding the anxiety is yes, they have been associated, anxiety, depression have been associated with RLS. And we are not, it's not completely clear which one is leading to the other one. But there is a very strong associated in between those two.
All right. Will there be any studies with daridorexant for
Yes,
RLS?
I tried to answer that one when I was mentioning the study that's now undergoing on survorexant. Daridorexant was just recently, I think a few months ago, approved by FDA for treatment of insomnia. We hope we'll see some studies specifically with daridorexant and RLS, but they're not right now to my knowledge. It may change
All right.
today or tomorrow.
Yes.
But I did not get a chance to go to clinicalstudies.gov to check on it, but not to my knowledge.
Okay. Do PPI or H2A medications make RLS worse?
Yes, that has been reported last year in an observational, very well designed observational study. So I'll definitely suggest caution with that. And looking at the personal experience and also discussing with your physician.
All right. Are there any decongestants, steroid nasal sprays, or antihistamines that won't cause my RLS to worsen?
Antihistamine can worsen restless leg syndrome, and that's we already know. And there is a lot of material on the RLS Foundation website to that extent. You may want to check with your doctor, and you may consider a saline solution that does not have any antihistamines. They are saline, different saline solutions are available for purchase, or you can have your own. But definitely you need to check with your doctor first. Those are, when I'm talking saline, those are used in all kinds of sinus rinses and stuff like that, but that can help.
All right. Are there any natural remedies that are effective for RLS symptoms?
I'm always suggesting caution when we are talking about natural remedies. I'm not sure what's natural remedies. Most of the medications that have been eventually started have some natural origin. So what makes one natural? Most of those natural remedies that I see referred to tend to be uncontrolled by the FDA, meaning that we don't know what's inside. And that's a big question mark. They are promoted as natural, organic, and so on, but we really don't know what's inside. We don't know the quantities. So I'm not sure. The other side of the natural remedies may be changes in behavioral and lifestyle changes.
All right. Are there more severe forms of RLS in some people, and what are contributing factors?
Yes, like with any disorder, some people have it mild, moderate, or severe. As I mentioned, there are two types of restless leg syndrome. The one that tends to start earlier in life, that tends to be insidious, but overall less severe. Again, RLS symptoms are perceived by the patient. So it's a perception also and the sensitivity to it. And sometimes during periods of anxiety, during periods of depression or stress, excuse me, RLS symptoms can to be worse, or the perception of them is worse. So yes, symptoms that developed after the age of 45 in more late adulthood tends to progress more rapidly and be more severe. Now, so one contributing factor is the age of onset. Other contributing factors include sleep, and mostly sleep deprivation.
All right. Does any food trigger RLS?
We do have pretty good data that caffeine and alcohol do trigger restless leg syndrome symptoms. Caffeine is in chocolate, and tannin, that's a substance in alcohol, is also can be found in dark fruits, a reddish color dark fruits, and in nuts. So usually my suggestion is definitely to decrease caffeine and alcohol, mostly red wine. And regarding the rest, the fruits and the nuts, it's based on each patient experience and see what triggers restless leg syndrome in their case.
Does RLS always get worse over time?
Not always, but yes, it does. It does tend to get worse in adulthood and late adulthood. Interesting enough, in the elderly, symptoms don't seem to be as severe as before. But that's again a lot of anecdotal evidence. It's not clearly studied in that extent, but we do know that it's a disease that tends to progress, and the progress, as I mentioned, tends to be more rapidly toward more severe symptoms in those patients that RLS started in adulthood, 45 years and older.
How do I find an RLS practitioner in my area?
Oh, I think you can answer that one much better than me. It's,
Yeah.
you can go.
Well, so I would like to answer that because we are in the middle of a project trying to find more healthcare providers who have good experience treating RLS. And we're getting that from members. So we have a pretty big list, but we're trying to get permission from those healthcare providers to list them on our website. So if you don't see anyone listed in your area on the website, give us a call or send us an email at info@rls.org, and we can give you the names of doctors that some of our members have recommended if we have them in your area.
And if I add to it, okay, sorry about that, Debbie.
Go ahead.
Okay, if I may add to it an additional suggestion, in addition to the RLS website, RLS Foundation website, you can also check with a provider that's not really in your area and they may know of, because we are a relatively small community and we do know each other. And many cases I'm getting questions about that. I'm referring to providers in specific areas.
Yes, and then also I should mention that we have providers at our quality care centers all over the United States, and that they are listed on our website as well. So let's see, how do you combine treatment for RLS and peripheral neuropathy?
Probably, again, first of all, I would suggest, number one, to discuss it with your probably neurologist in this case, or even primary care physician. But my suggestion would be to try the alpha-2 delta ligands, the gabapentinoids, that are useful for peripheral neuropathy and extremely effective for restless leg syndrome as well.
All right, and how do you deal with RLS augmentation when you have a patient who is taking levodopa to treat Parkinson's disease?
That's extremely tricky because if you cannot get off the levodopa for Parkinson, RLS symptoms can become very severe. One option would be to discuss it with your movement disorder specialist to see if there is any other option, a longer acting dopamine agonist that you can use to treat Parkinson's disease. And the rotigotine patch was used for Parkinson's disease, and the longer the longer range that a dopamine agonist has, the less inclined is for augmentation. Also, keep in mind it's extremely important to maintain iron stores to make sure that iron stores are replenished enough. It's possible, and discuss it with your doctor, that an IV iron might be something that may help you with your RLS symptoms as well. But again, your movement disorder specialist, usually they do tend to be to have a broad knowledge of restless leg syndrome as well, so they can give you good suggestions, I hope.
All right, I'm having knee replacement soon. Any advice on healing or info I should share with my surgeon?
Sure, go to the RLS Foundation website. There are brochures for surgeries that they have. And maybe you can correct me if there is more information, probably on different issues of night walkers. There may be some information. Definitely, I would suggest to take one of those brochures to your
Yes.
surgeon.
Yes, we have a really good brochure that you can take with you to the hospital. And so either if you're a member, you can download it from the website, or you can email us at info@rls.org. And we'll send that to you.
Exactly. And take it to the surgeon too, not just to the hospital.
Right. Yeah. Anybody that's going to be working with you should be, yeah. Mhm.
The
Nurses,
surgeon, the
doctors.
anesthesiologist, when you are going for your pre-op with the anesthesiologist, take it and add. Also, if you are on medication for restless leg syndrome, there may be a need to adjust or to find, maybe go on the patch if you cannot get anything orally. So there may be some things that need to be adjusted. And it also depends on the dose of the medications that you are for RLS. So you need to talk with your doctor and bring the information to both the surgeon and the anesthesiologist that probably are not as familiar with RLS.
Right. And we also recommend that you bring your RLS medication with you, because some of them are not easily available at hospitals. So yeah, but the handout that we have spells all that out. So it's really useful before surgery. Well, that's all the time we have now. Thank you, Dr. Sharon, very much. You've been very helpful. And if you'd like to come to another webinar, go to our website, click on Education and Events, and it's under the Get Involved tab. Thanks so much for joining us, and have a great day.
Thank you all. Thank you. Bye-bye.